Hi, Dr. Leininger. This is Latrita Hillman-Evans, and I opted to do the video option for week 3 assignment to step out of my comfort zone and to get used to doing video recording. So the assignment is Schizophrenia Spectrum Case Analysis and Treatment Plan. And the assignment requires me to analyze a client in an initial session and describe their symptoms, develop a diagnosis from the various options located in the schizophrenia spectrum, and then articulate a preliminary systems-oriented treatment plan. The video was that of Efren, a 23-year-old heterosexual, single, second-generation Filipino male who resides in San Diego with his family. He lives with his mother and father, who migrated to the United States. His father is in the U.S. military, his mother is a nurse, and his sister, who is 8 years his senior, lives within the home. She has lived inside and outside of the home, but she currently lives within the home. Efren came to therapy at his family's urging to seek services because he became paranoid of those around him and locked himself in his room for the majority of a week. When his family and friends tried to help him, he accused them of secretly trying to monitor his behavior and trying to hurt him. He was admitted to a hospital on an involuntary hold where he stayed for a week and was stabilized on medications. He then returned home approximately 2 weeks prior to the video recording and is now looking to return to school and his work and regular functioning. So he did come to therapy at his family's urging, but he is looking to resolve his current symptoms and to resume a life of normalcy. So the symptoms that I noted for Ephraim included delusions, more specifically persecutory delusions, which refers to belief that injury and or badgering to self from a person or group of people is imminent. Some of the examples I noted from the video is that during the initial interview, he described that he got clues that others may be monitoring him because his family were asking a lot of questions about what he was doing. His family and friends tried to assist him. When they tried to assist him, he made accusations that they were secretly monitoring his behavior and trying to hurt him. And after locking himself in his room, the client states he would hear footsteps outside the door and he would turn up the music so as to drown out the noises, and so those outside the door did not know what he was doing. There were two things that I noted as contrary proof that make delusion symptoms fit in this case. I noted that the family and or friends, instead of them monitoring him, could just be reporting or checking on him in a normal form of relational and daily communication with him. And instead of his perception of injury and or harassment, it could be that his family was checking on him or communicating with him in response to his mental and emotional state to be sure that he was functioning okay. Well, the second symptom I noted was hallucinations, which is describing or having sensory encounters, in this case audio encounters that take place absent of an outside source. The encounters are involuntary, yet they have the complete effect as though they fit within the range of normal or common encounters. These auditory hallucinations are comprised of typically hearing known or unknown voices separate from one's personal thoughts, and they're unrelated to the client's religion or cultural practices. One example is that Ephraim indicated that after being asked by the clinician that he hears multiple voices that tells him things to do that most he did not recognize, but he did recognize one specifically as his recently deceased grandmother's voice. He said some of the voices are critical and some are supportive and encouraging. The client possibly heard an auditory hallucination during the initial interview indicated by his glancing upward, which was a behavior that did not fit within the range of what was taking place within the therapy session. Regarding effect, he stated that the voices can be critical and encouraging. He didn't mind them at times, but he did have to battle them every day and sometimes felt like he would was going to lose the battle. The third symptom I noted was avolition, which is diminished desire and or interest in personal activities, including social and work activities. One of the examples that I put is that during that period where Ephraim was locked in his room, that he did separate himself from those who could potentially harass or harm him, which meant that he was not functioning in his social and work activities that he would normally do. I did note, however, that I was not certain about this symptom. I noted in the DSM that there was a severity chart that would possibly allow me to rate this as low severity in terms of utilizing it as a symptom, and doing so because he did indicate that he did want to get back to normal activities. As a description of the disorder, the diagnosis I believe best describes the client's symptomology at this time is schizophreniform disorder. The symptoms of the disorder are similar to schizophrenia, but what differentiates it from schizophrenia is primarily the length of time coupled with future prognosis. The diagnostic criteria for schizophreniform disorder include that it falls under the description of a psychotic disorder. It includes severe and persistent atypical thoughts, perceptions, and emotions that manifest in the form of delusions and hallucinations, followed by behavioral dysfunction. The criteria for this diagnosis includes at least two of the following: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. The two noted negative symptoms were reduction in expression of emotion in body language and or speech, typically used for emphasis during communication, and avolition, diminished desire and or interest in personal activities, including social and work activities. The episode duration for this disorder is between 1 and 6 months. I did note per the DSM that since this diagnosis is being made early on without a recovery period, that it qualifies as provisional, meaning it could later qualify for a diagnosis of schizophrenia, which is coupled with a minimum of a 6-month period of showing the symptoms. I ruled out there were two items that I needed to rule out. One was schizoaffective disorder and depressive or bipolar disorder. There could possibly be depressive mood episode, but I didn't feel that there was enough evidence that I saw that there was such. So I felt pretty confident in ruling out that the schizoaffective disorder and depressive or bipolar disorder. The second was ruling out symptoms linked to substance abuse and or other medical conditions. There was no indicating of such, so I felt comfortable ruling that one out as well. In regards to the specification of presence of good prognostic features, the client appeared to have possibly reduced premorbid social and occupational functioning, but that social and occupational functioning being reduced could also be a result of environmental and relational factors, namely cultural context. He noted that there was a hierarchy within his family structure that required a strong patriarchal presence and authority. And the other thing is that his social and occupational functioning could be a result of the discrimination and or bullying behaviors that he experienced during elementary and middle school. As far as etiology and causes for the disorder, the development description is interchangeable for the most part with that of schizophrenia. There are possible brain abnormalities that are associated with the disorder. Risk factors for the onset of the disorder include environmental risk factors. There has been noted research that urban areas and some minority groups have a higher risk. Genetic and physiological. There are some pregnancy and birth complications that indicate higher risk as a possibility. There are gender risks. Diagnosis is moderately higher in males versus females. The last thing I noted is that the cultural considerations must be reviewed and understood to rule them out. In other words, the client's practices could be contextual practices related to his culture as opposed to symptomatic behaviors. The course of this particular disorder, development in the form of the first episode, typically begins in late teens through early 30s with a steady increase in the symptoms. Recovery is within 6 months with no additional diagnosis thereafter. However, there was indication that most people initially diagnosed with this disorder do transition sometime after the 6 months to a diagnosis of another psychotic disorder such as schizophrenia. The effects, both individual and systemic, of this disorder include individual and systemic challenges with regular daily functioning, frustrations, misunderstandings of the behaviors, grief associated with loss of homeostasis or balance within the family and relational system, stress, stigmas, interruptions of what client and family considers normal daily activities and functions, additional caregiving responsibilities of the family, and discrimination from within and outside of the family system. For those whose symptoms do not extend or escalate beyond that associated with this disorder, meaning beyond 6 months, the effects of the actual disorder are less prominent and less likely to be long-term compared to that of schizophrenia. There is a return to a level of normalcy in terms of cognitive, emotional, and social functioning. So treatment planning. The model that I chose for this particular disorder is solution-focused model. The relevance of the model for this case and how it fits is that solution-focused treatment is beneficial for use with this case and a good fit due to its focus on the future and solutions with little attention given to the presenting problem. There's an assessment of client strengths coupled with optimism and hope that will be helpful for both this client and the family as a whole, because it is difficult to pinpoint the causes of schizophreniform disorder, so spending excessive time analyzing the origin of the problem is likely not going to be very productive. There's an emphasis on optimism and hope that presupposes that people are always changing and seeking to maintain homeostasis. It is a future-focused model, and it's aimed to assist the client in reaching their fullest potential. This client states he does want to get back to his previous state of premorbid or normal functioning, and this model supports those efforts. It is a fervently optimistic model with respect to a client's ability to reach their goals and their fullest potential, and I think it would be beneficial considering the stigma that can be attached to this order. There is heavy stigma that may elicit negative reaction, and so optimism, I feel like, the optimism of this model would balance out that negative stigma and create, hopefully, an environment where there is hope. The positive nature of solution-focused theory is change-centered and can be the facilitation of new life meanings that are translated into the vision that the client desires for their life. There is an element of discovering strengths and resources of the client and family through solution-focused questions and tentative listening, and that can be a gateway for solutions and change based on the choices of the client. Considering Ephraim's personal strength and resiliency and his desire to appease his family with which he has a strong bond, I believe solution-focused therapy will support those desires by assisting him in creating ways to balance his desired solutions. This model promotes revisiting behaviors that the client used to navigate successfully during the pre-symptomatic period, which could be utilized to help move forward with future goals. The therapist's role is that of the beginner's mind and one of curiosity that leaves both the therapist and the client open to the client's own personal narrative of their life experiences. Seeing as I'm not familiar with a lot of his culture, it would behoove me to keep a relationship that in the form of a curiosity and approaching this relationship as a blank canvas concerning any of my presumptions. I would be following the client's lead with the client as the expert on what's best for him and embrace and support his unique experiences and assist him with a view of his possibilities. Taking into consideration the client's cultural context means, again, that I would be able to keep a curiosity that would teach me and keep me open to the cultural context and allow me to navigate through his personal experiences to move towards his goals. The two interventions that I would use are solution-focused questions, which are the navigational tools for understanding how to best facilitate the client's desired result. The client is already optimistic and taking the initiative to make changes in his life. Although encouraged to go to therapy by his family, he does express the desire to satisfy his family and to get to a state of normalcy. Coping questions and use of miracle questions and scaling questions, they would highlight the strengths, the family support, the optimism, trusting his therapist, which is I believe is a strength that he possesses, his desire to be better, and his resiliency. The second intervention would be family psychoeducation. The client's family could use further education regarding this disorder, as well as support in navigating his expectations and alleviating familial stress and eradicating possible stigmas associated with the mental illness. Psychoeducation would do that in that there's an emphasis on the family as a support for the client's recovery. This approach fits well with solution-focused therapy, and that the goal is to reach the client's potential and successful outcomes. The focus is solution-based, as well as supporting the family as they support the client moving towards and maintaining recovery.